My name is Terrence Healy, and I'll be speaking last. Thank you for having me, Dr. Vlahos. And we have a great panel here about lung cancer screening. If we have time at the end of the floor talks, we will have time for questions. But until then, let's get started. Just a reminder, please, everybody, if you have your phone, just kindly turn the noise off. And we're going to start with Dr. Prosper, who's going to talk to us about implementation of LungRADS version 2022 in clinical practice. So please welcome Ashley.
Thank you so much, Terrence, for the warm welcome. Thank you all for being here early on a Thursday morning. So today, I'd like to start out by thanking Dr. Jared Christensen, who contributed many slides to this presentation as chair of our LungRADS committee. I'd also like to thank our entire LungRADS committee, including my colleague Jonathan, who's going to speak to you later today. What my goal is today is to cover some of the highlights or updates from LungRADS version 2022, which launched in December of 2022, just around the time of RSNA. Still relatively new, and people are getting accustomed to it. We're going to also talk about some topics that occur after the scan and improving follow-up. So for those who may be new to screening, we know that lung cancer screening eligibility has recently expanded, and so we've seen a doubling in eligibility, and many people may be now performing lung screening interpretation where they did not before. What we know is that when we're looking at pulmonary nodules, we are able to describe them using semantic features, describing things such as the margins of the nodule, the solidity, the size, the location. And what we're doing with LungRADS is we're really formalizing this interpretation and structuring it in a way such that an individual who is scanned, say at my home institution at UCLA in Los Angeles, or at your home institution, wherever that may be, will receive similar guidelines and follow-up. We know that looking at some of these semantic features, things like the density of a nodule, the size of it, the shape of it, can help us predict the histology. We do not have magic glasses as radiologists, but we do get a good idea. For example, these are two nodules which I would describe in figure A as being solid with jagged margins. We took that to percutaneous biopsy and did see an adenocarcinoma. Similarly, this nodule, which I would describe as suspicious because of its part solid texture, resulted in an adenocarcinoma at resection. All right, so as mentioned, LungRADS is really structuring the reporting and the management of our screen-detected findings at lung cancer screening CT. What I like to remind everyone is that we've really only just begun. The NLST was published just in 2011, and while many things have changed from 2011, this is a relatively short period in our history, and LungRADS is really growing with us. So if we think about our LungRADS version 1, when we saw CMS really approving the coverage from lung cancer screening to a revision in 1.1, which mirrored some of the changes in the draft guidelines, and then ultimately version 2022 after our lung screening guideline update. What we try to do as a LungRADS committee is to be as evidence-based as we possibly can. Now, we realize that the evidence is evolving, and so when there is a lack of sufficient evidence, we end up relying on expert opinion. We discuss what is going on across the country, and we try to form the best guidelines to form this management. Now, why even bother using LungRADS? Well, we know that it really improves patient outcomes, and that is our ultimate goal as physicians. If we look at studies that have been published analyzing using LungRADS 1.0 when it was retrospectively applied to the National Lung Screening Trial data, we see that we saw an improvement in our specificity and sensitivity. Likewise, recently an exam or study looking at LungRADS 2022, specifically at airway-centered nodules, we saw improved specificity. Now, this is not an eye test. This is simply to remind you that LungRADS is available online. It is available on apps. It is something you can print out. You can keep it at your desktop. You can keep it on your phone. Do not worry about memorizing all of these guidelines. It is not a test. Even though I participated in updating LungRADS version 2022, I keep this printout near my desk, and it's very helpful to guide you. What we're going to do is quickly go through some of the categories for some who may not be so familiar. What we're doing is we're working through a scale from 0 all the way through 4. There are a few letters involved. Now, we'll use a 0 when an exam is incomplete or when we might suspect infection. I'll go over a little bit more detail about this in just a moment. For example, here, the scan on the left, you're looking at the lung bases. You see thickened airways. You see lots of little micronodules and ground glass opacities. Rather than characterizing any of these individual nodules, we'll say, you know what, it looks like this patient may have had a little aspiration, a little bronchiolitis. I'm going to defer giving any lung rad score at this time. I'm going to say that the exam is incomplete because of some infectious findings and have them come back within a short-term follow-up. If necessary, they might see their pulmonologist or primary care physician for some treatment. When they came back, the lungs are entirely clear. At that point, I can go ahead and give a lung rad score. The important thing is that they're not done. They need to come back. Now, of course, we have things that are negative findings or things that we are confident are benign. For example, in this case, we have a completely calcified, smoothly marginated nodule. We know that this is a calcified granuloma. We would be confident giving this a lung rads 1 for a negative exam. Now, our lung rads 2 category, these are nodules that are likely benign based on their morphology, and you'll see that there are several different categories, including our smaller, purely ground glass nodules, such as one that we see here within the left lower lobe. As we increase in numerical order, we are increasing in our level of suspicion. Lung rads 3 is when we look at things that are probably benign, but we want to see them with a shorter term follow-up in 6 months. This is a reminder that we're looking at mean diameters in lung rads. For example, this nodule, we would take the mean of 8 by 4 millimeters for a diameter of 6. At a baseline, this would fall within our lung rads 3. Looking at our 4A lesions, and we'll talk a little bit more about this in just a few slides. This is an example of a pericystic ground glass nodule that we have a heavier level of suspicion, in which case we are stepping up our management with either a 3-month follow-up. PET CT is an additional option if we have a sufficiently large solid component. Now, as we move to our level 4B, this is going to be our highest level of suspicion. This is an example showing you really the importance of having prior exams available. For example, when we look at this exam and we see a solid nodule measuring 10 millimeters in the lingula, we look in just a year prior, nothing was there. That really raises our level of suspicion. Now, as mentioned, we have many changes to lung rads 2022. A few that I'll highlight are atypical pulmonary cysts. We talked a little bit about infectious and inflammatory findings, and finally, juxtapleural nodules. All of these topics are covered in the lung rads manuscript published in both the JACR and CHEST journal. Now, atypical pulmonary cysts, the reason that we really focused on this is because we know that when we look at cancers that were initially dismissed on screening, it's frequently because they're associated with cysts. To remind you, smoothly marginated simple cysts are not classified in lung rads. That is not what we are looking for. We are looking for cysts which are suspicious either because they're thick-walled or nodular or multilocular or evolving over time. When we look at our unilocular cysts, if they are thick-walled, that means that they have at least a wall thickness of 2 millimeters. They may be either thick-walled at baseline or become thick-walled. Those would receive a lung rads category 4A. We are also suspicious of multilocular cysts, which are either multilocular at baseline or become multilocular over time. Those would receive a lung rads 4A. Now, we remember that thick-walled cysts can evolve over time. For example, this is a cyst which grew. We see increasing pericystic solid component. We are increasingly suspicious of that. That would be an example of a 4B. Now, I want to remind you that you want to manage nodules based on the most concerning feature. For example, here we have a lesion which has a thick-walled cyst. It is a little bit multilocular. It has an exophytic nodule. I'll give you an example here. If we measure the nodular component, measure 6 millimeters. If we based our management on that nodule, it would receive a lung rads 4A. If we looked at just the fact that it has an exophytic nodule, that would be a lung rads 3. I'm sorry, I misspoke earlier. The thick-walled cyst would give us a 4A. And so we're going to manage this based on the fact that it is a thick-walled cyst. So you want to look at your lung rads categories, see whichever gives you the highest level of suspicion and the soonest follow-up, and that's what we'll choose. Quick highlight on juxtapleural nodules. We know that there are several areas of pleura. We have our periphyseal pleura. we have our costal pleura, and we have our mediastinal pleura. And what we did with LungRads version 2022 is we extended looking at our juxtapleural nodules to not just the periphyseal nodules, but all of the juxtapleural nodules. Things to remember is that for a juxtapleural nodule to be categorized as likely benign, it needs to be less than 10 millimeters, have solid margins, and an ovoid, lenticular, and triangular shape. It must possess all of these features to be considered benign. Here are some examples here. Now, just because a nodule is next to the pleura does not mean that it is necessarily benign. For example, we have nodules that are not ovoid, nodules that are not lenticular or triangular, and nodules that are not solid, and so we would not give these a LungRads 2. We talked a little bit about infectious or inflammatory findings. I will skip past this in the interest of time. Lastly, I'm going to discuss infection, because I think this is one of the more challenging issues. We have some options with LungRads. If we have a new area of consolidation, for example, here, what we could do is say, this is an incomplete exam because I am suspecting a segmental pneumonia. This patient should be treated and come back within a short-term follow-up. They could get a LungRads 0. Alternatively, what we could do is we could say, you know what? As I scroll through this looks more like a mass-like area of consolidation. I'm worried perhaps of a mucinous adenocarcinoma. I want to give it a LungRads 4B and do more advanced workup. Now you look at the difference in timing here, and it may result in a difference in workup in about 1 to 3 months. And what I would say is that really the best way to do this, if you're not sure, is to remember that you're not an island in and of yourself. You do have a multidisciplinary team. And what I would encourage all of you to do is to establish a multidisciplinary nodule conference to meet with your fellow diagnostic radiologists, interventional radiologists, pulmonologists, thoracic surgeons, radiation oncologists. This is something that we do quite frequently at my institution. We discuss our next best steps. We decide on the management of all of our LungRads 3 and higher exams together. And that is really great because it ties the patient into the system. We make sure that we have appropriate follow-up. We enter a note about our decision as a multidisciplinary team into the EMR, and then we proceed. So there's so much more that I was not able to cover today, but I would encourage you to take a look at the LungRads manuscript. We are continuing to work as a committee to provide additional documentation to help you with your interpretation. Please take a look at the ACR LungRads website for additional guidance, and thank you so much for your attention.
Okay, next I'd like to introduce Dr. Agarwal from Brown University. He's going to tell us about cystic lung lesions, a practical approach on low-dose lung cancer screening. So thank you, Dr. Agarwal.
All right, thank you for having me. So now I'm going to do a deep dive into cystic lung lesions and how we can approach these when we're looking at these on low-dose lung cancer screening CT. All right, no disclosures. So the way this talk will be organized is first we'll talk about what is a cyst and how to differentiate that from emphysema or a cavity. Then we'll talk about cystic lung cancer, which Dr. Prosper talked a little bit about. And then we'll really go into this concept of the atypical pulmonary cyst on low-dose lung cancer screening CT. We'll talk a little bit about LungRads version 2022 and what we should do if we see multiple lung cysts, and then talk about some mimics as well. All right, so what is a cyst? So this is taken directly from the Fleischner Society glossary. A cyst is any circumscribed and well-defined air-containing structure in the lung parenchyma. So you can see this example right over here. Let me go over here. So it appears as a circumscribed and well-defined radiolucency with a low attenuation area with a thin and usually regular wall. As you can see in this case over here, there are multiple lung cysts. You can see that radiolucent area and this kind of thin and regular wall. So how do we tell this apart from emphysema or a cavity? So some helpful hints are: one is that a cyst is generally round. It has a well-defined and thin wall, and that's usually defined as less than 2 millimeters in thickness. It's interfaced and surrounded by normal lung, and it'll lack a central core vessel. Now, this is in contradistinction to emphysema, which usually will be without visible walls, often has an upper lobe predominance, and something that can be very, very helpful is to look for that central dot sign, which I'll show you in just a few minutes. Now, one thing that comes up sometimes is people ask about blebs or bullae. Oftentimes, you won't see kind of that central core vessel in those, but in general, those are upper lobe predominant. You'll see many of those, and they're at the periphery. So with a cyst, it's usually not that way. It's usually surrounded by lung. Now, cavities, these are irregular, they're thick-walled, and they're often associated with consolidation, mass, or nodules. So the cavity, oftentimes the wall is a defining feature of that. All right, so here are some examples. So in this patient over here, if we look and we're trying to decide, is this a cyst or is this emphysema? We can look over here and we can see that there's this thin, well-defined wall, this radiolucent area over here. It's surrounded by lung, and we do not see any kind of central core vessel or any sort of vascular bundle going through there. Now, if we look at this area over here, if we look at this, it kind of looks similar, but what you'll notice is that it's a little bit harder to define the wall. When we're looking at these are actually pulmonary vessels kind of coming over here, and then you do see this little thing right in the middle over here, this little vessel, and so this is emphysema. Now, what about this one over here? This is a great example of that central dot sign. So if you see something that looks like this, and you might be thinking to yourself, is this a cyst? It kind of looks like it has a little bit of a wall here. But then you see this and you know that this is emphysema. Now, it might be a little bit easier when you have, just one or two of these, but what about when you have something that looks like this? And sometimes we do come across these cases, and certainly at our institution, when you go back to the prior reports, sometimes you'll see, sometimes we're calling it multiple cysts, sometimes we're calling it emphysema. So how can we approach this? So when you look at this, we'll pick out some lesions over here. So if you look at this, you'll notice that there is this thin, regular wall, and you look in the center and you do not see any vessels or any kind of central dot sign. You can look at this one over here, same kind of thing. And the more and more you look, you won't see that any of these have that kind of central core vessel. And so this is a case of multiple lung cysts. This was lymphangioliomyomatosis. Now what about this one? On a cursory look, this might look very similar to the last case I just showed you, but as you look more closely in this case, look at all these areas of radiolucency, and you'll notice in the center, there's that central dot. And this is happening over and over and over. And so in this case, you're not talking about cystic lung disease, but you're talking about emphysema. All right, now a cavity, this is when you have an irregular thick wall. It's often associated with consolidation and ground glass. As you can see in these two cases, the defining feature, although you see a little bit of kind of lucency in the middle, the defining feature is everything else. So this first case, this was a squamous cell carcinoma, and this was a case of cavitary infection. All right, so what is cystic lung cancer? This is lung cancer that's associated with cystic air spaces. And this is something that we are seeing more and more, mainly because we're doing more screening. And so some studies have shown up to 4% of cases, other studies up to 9% of cases are associated with cysts, but this is likely underestimated because we're oftentimes not recognizing these. Now, the important thing, why we're really touching upon this, is that this is often a cause of missed and delayed diagnosis. So one study showed up to 22 to 23% of cases of cystic lung cancer were missed on low-dose lung cancer screening CT. And the main reason for that is just that we're not aware of these types of lung cancer. So just a little bit of background on cystic lung cancer. The exact carcinogenic mechanism is unclear. There are two main competing theories. And so the first is that you have a pre-existing cyst, and if that's sitting there in the lung, that interferes with normal ventilation. So if you are out there, you're smoking, all of those carcinogens are kind of depositing in the cyst, you can't clear them, and that leads to lung cancer. The second theory is that you already have a microscopic cancer, it's in a small bronchus, and you cannot see it when you look at a CT. And because of that, that leads to this check valve effect in the small airways, causing the formation of a lung cyst, and then later when the cancer gets bigger, that's when you can actually see it on a CT. Now, one thing to keep in mind is that these are not cavitary lesions. When we resect them, there's no necrosis. Now, what about subtypes? In general, if you have 10 of these, 8 to 9 of them will be adenocarcinoma. That is by far and away the most common subtype of cancer when you resect these. Now, squamous cell carcinoma is the second most common, and there have been cases out there in the literature of small cell lung cancer presenting as cystic lung cancer as well. All right, so we talked a little bit about this, but I'm really going to highlight this because this is very, very important. So LungRADS version 2022, they have new criteria and this concept of the atypical pulmonary cyst, which we'll talk about. But before we mention that, remember that if you have a thin-walled cyst, so you have just kind of those cysts I was showing you earlier where they're unilocular, they have a thin and regular wall, those are considered benign. You can just look at them, you don't have to mention them, and just kind of move on. So two main types of atypical pulmonary cysts. The first is a thick-walled cyst. This is when you have a unilocular cyst with a uniform wall thickness, asymmetric wall thickening, or nodular wall thickening, and we'll look at many examples in just a moment. The second type is a multilocular cyst. This is a thick or thin-walled cyst where you have internal septations. Now, you do want to differentiate this from a cavitary nodule, because in those nodules, the wall thickening is the dominant feature, and you want to manage those as you would a solid nodule. So you take that average diameter and just go down lung rads for those. So here's a nice example of a thick-walled cyst. In this case, you can see that there is a right lower lobe cyst over here, a little bit of wall thickening, but the main important part here, you see this kind of nodular wall thickening. Here's another example over here. You see that in the left lower lobe, there's this multiloculated cyst with all these internal septations and some wall thickening. So how do we classify this? We talked a little bit about this, but I want you to remember when you see an atypical pulmonary cyst and you're looking at your lung RADS chart, you can just start at lung RADS 3, because at that point, that's where we start talking about atypical pulmonary cysts. So a lung RADS 3 would be if you had a cystic nodule that was there, but the cystic component is growing, but the wall thickness is not. Now, a 4A, this would be if you have a thick-walled cyst, a multilocular cyst at baseline, or a thick-walled cyst that becomes multilocular. So here's an example over here. You see that there's this multilocular cyst, and you see that there's some wall thickening, so this would be a 4A. Here's another example over here. Again, you have this cystic lesion, some wall thickening, and once again, this would be a lung RADS 4A. Now, what about this case? So in this case, this patient has this cystic lesion over here. There is a little bit of wall thickening. It's slightly over 2 millimeters. But when the patient came back, you'll notice that the wall is thicker. And we measured it over here, but especially over here, it looks quite a bit thicker. And so in this case, this is a lung RADS 4B. So this is very suspicious. This is when you have a thick wall cyst with a growing wall thickness or nodularity, a growing multilocular cyst, or a multilocular cyst with increased loculation or new opacity. Now, one thing I do want to mention is that when you're talking about measuring these things, and it's such a small number, it's in general you have to be over 1.5 millimeters over 12 months. So if you saw it and it was very slightly bigger, sometimes that can be slice selection or just the way you're measuring. All right, so here was a really good case from our institution. This patient went to get a low-dose lung cancer screening CT, and this was mentioned as a ground glass nodule. It's less than 3 centimeters, so this was given a lung RADS 2. Patient came back 12 months later, and what you'll see here is that this lesion looks a little bit different. In fact, when you look now back where we thought this was normal lung, this actually was an early cyst, and you see that it's gotten more cystic, has all these septations. This was then thought to be suspicious, and this was eventually resected, and this was an adenocarcinoma. Now, what about this case? I showed you this case earlier. So this was a case where we have, this right lower lobe cyst, this little nodular component. And unfortunately, on this case, we didn't recognize this, because this, this looks like a cyst, and we weren't really thinking much about this. Patient got lost to follow-up and came back a few years later, and look what it turned into. So we're talking about these, but these don't have to be, the last one I showed was kind of slow growing, but these can be quite aggressive. Here's another case that was shared by one of our colleagues. This was a patient, once again, has this right lower lobe kind of cystic lesion, has a little bit of wall thickening, and again in this case, we didn't really make much of this. This was many years ago, and patient was lost to follow-up, came back a few years later, and unfortunately now, you can see that the cystic component hasn't changed too much, but look at all of this thickening all around. This was avid on PET, and on mediastinoscopy had positive nodes. So very, very important to recognize. All right, so there have been multiple talks on multiple lung cysts. There's a lot of educational exhibits. So I do just want to highlight that if you see multiple lung cysts on a low-dose lung cancer screening CT, that indicates an alternative diagnosis such as Langerhans cell histiocytosis, most commonly in smokers, or lymphangioliomyomatosis, or other things. And those are not classified in lung RADS unless you see something else that is concerning about them. So just some cases of multiple lung cysts. This is probably the most common one you'll see in smokers. Upper lobe predominant, multiple irregular, bizarre-shaped cysts. Oftentimes they're sparing of the posterior costophrenic angles. Here's a case of LAM. And then if you have the right history, Sjogren's disease or HIV, and you see lower lobe predominant cysts, you might think about LIP, or lymphocytic interstitial pneumonia. Now, what about some mimics? This one is an exaggerated mimic, but just to remind you, if you see a cystic lesion, as we're kind of looking here, this patient actually has just multiple bullae, but you see an air fluid level, as you can see over here, then think about infection. You might still get a short-term follow-up, but I wouldn't jump to say, this is something very suspicious. Air fluid levels often signify that there is infection. And then here was a very nice case. So this case we actually called. You can see that there's this area, it's in the right upper lobe, kind of looks multiseptated, looks like there's some thickening. This was thought to be very suspicious, and the patient got a follow-up CT in 3 months. And what you'll note here is that this area actually improved. And so this probably was some inflammatory change, just kind of around either a pre-existing cyst or some emphysema. And so not all of these cases, just because you see it and we've shown some cases, they're not always malignant. And so just keep that in mind, and sometimes what you need to do is just get a short-term follow-up. All right, so just to take away, this is from LungRes. Just remember that lung cancers associated with cysts are not uncommon. It's just that we haven't recognized them in the past. And if you see one on low-dose lung cancer screening CT, go down your chart and start at LungRADS 3 and kind of follow those recommendations. So if you see a cystic lesion that is growing the cystic component but the wall is the same, you might get a short-term follow-up in about 6 months and give it a LungRADS 3. If you see a thick-walled cyst on baseline or a multilocular cyst, give it a 4A and get a 3-month follow-up. And then if you see that wall getting thicker, greater than 1.5 millimeters, then that should be a LungRADS 4B. All right, and then just remember that if you have cavitary nodules, you should treat them as a solid nodule and use the average diameter. All right, thank you very much.
Next, I'd like to introduce Dr. Chung, who's going to talk to us about lung cancer screening and large language model. So thank you, Dr. Chung. And
well, thanks for that kind introduction. And so it's a pleasure to be here. Just a little bit a shift here in terms of what we're going to be talking about. But we're going to talk about LLM. So let's talk about some learning objectives first. So if after this talk, you guys could better identify how large language models can help with non-interpretive tasks in lung cancer screening. You can create basic prompts in LLMs, specifically ChatGPT, because that's what I'm most familiar with. And then you can create simple programming code using LLMs. All this sounds daunting, I know, but it's not, I'm telling you. For LLMs, I feel like I would have been successful. All right, so let's just get everyone on the same page. Okay, what the heck is an LLM? I think everyone knows. Everyone's heard of ChatGPT, Bard, Gemini, all of these things, right? But bottom line, it's an AI algorithm, more or less, that's trained on a lot of text-based data, usually from the web, but it can be from all sorts of sources. And then what it's good at is, because it was trained on text, it's good at generating text as well. And at first I was very skeptical. When ChatGPT first came out for public use in 2022, I was skeptical. I said, well, what is this? How interesting could it be? And obviously, usually these things come out on social media. So it first came out on Twitter, people are talking about it. I tried it out and it kind of blew my mind, right? The first use case was like, I had to create a story for my kids. So that because they keep asking me to create stories myself, very hard right after a while. And so they did it for me and I was like, wow, there's actually possibilities here. So there are a lot of use cases in medicine as well if you have a little bit of patience and a little bit of imagination. So these are different steps in any imaging examination. So that you have the ordering step, obviously you have the acquisition of the CT and the protocoling, the actual interpretation, creating the report, and then communication with both the patient as well as a clinician. And I tell you, every one of these steps, either to a greater degree or a lesser degree, you can use an LLM to augment that, to improve it. Specifically for lung cancer screening workflow, these are the key stages that we're looking at. And so actually we have our patient identification, people are appropriate for lung cancer screening, scheduling of patients, protocol optimization depending on the patient's size and other factors as well, the imaging acquisition step, and then the interpretation, reporting, and patient follow-up. And again, every one of these LMs could be utilized. But in 15 minutes, we can't go through each one of these. So these are the 3 use cases where I'm going to just exemplify how you could use LM and some situations where I actually am using LMs for my own clinical practice. So again, not daunting. This is actually really easy. Just as an aside, sometimes people will look at me and they say, "You look smart." I don't know if that's an insult or not. Right? You look smart, right? But they think like, "You look smart. I bet you know how to code and all this." I don't know how to code. I've never C++. I don't even know what that is, right? Never did in high school. I have no IT informatics background. I'm a quality person, also is a chest radiologist. But LLMs are amazing, and so I'll just show you with these few use cases. So the first thing we're going to talk about are these patient pre-scan handouts. And so this is really before the patient gets their scan, they're supposed to be scheduled for lung cancer screening to kind of just give them an idea of what to expect, maybe how to prepare. Obviously, for lung cancer screening CT, you don't really have to prepare, but this could be obviously extrapolate to other types of imaging studies as well where there might be a prep. And so look at how simple my prompt is here in ChatGPT. It's literally 2 sentences long. In a matter of seconds, it gives me this link, and I'm able to download this, right? And it's a whole PDF. Here's a QR code, so if you actually want to see the whole thing, it was about 2.5 pages, so I couldn't include it here. So I include this, oh wow, very large QR code when it's projected like that, but you should be able to download that, and I'll keep it there for, I don't know, pretty much forever. So you can keep that QR code with you and share with others. So you have this. This is great, right? So did I give everyone enough time? I think so. A couple people still taking pictures. I'm just going to be patient. Okay, perfect. All right, and the great thing about these LLMs is that they have some memory to them. So they can actually, you can ask it to, you could tweak things. You could look at it and say, this is good or great, but I want something else. So here, just because I want to see what it could do, I just asked it, well, add a little blurb about radiation, because obviously patients are scared about radiation for these lung cancer screening CTs. And again, in a matter of seconds, it included this within the PDF as well. So you don't have to read this, but obviously if you, I guess maybe you do have to read it, but I'll just describe it to you. More or less, it's a very simple patient-centric description of the amount of radiation they would expect to get, and sort of the fact that it's a very low-risk radiation exposure. The benefits outweigh the risks. So you can ask the LMs to write this text in different voices and for different audiences, which actually makes it especially powerful as well. So we've already defined that this is for patients, so it's writing in this patient-specific way as opposed to for clinicians. All right, so that actually I think is the simplest utilization of an LLM. It really is. So again, LLMs, they were trained on text. They are very good at generating text. And so that is like a no-duh use case. Everyone can do that. So if you were tasked at your local department or in your hospital to start creating patient-specific content, PDFs, websites, stuff like that, LLMs, you should start with LLMs. If you're doing it by hand, starting from scratch, you are doing it the wrong way. You know, it's not 1996 anymore, right? It's 2024. We have tools available to us that can make our lives so much easier. So for these non-interpretive, non-RVU-based tasks, can make your life so much easier. I do encourage you to leverage that. I have no financial relationship with ChatGPT or any of these LLMs. It's just something that I do believe in. Okay, so that's the simplest use case. Let's go to something a little bit more complex. We're going to switch gears here a little bit. And so next thing we're going to talk about here is this, structured reporting, okay? And so, the idea here is to use LLMs to structure your reports and then also to help you make lung rads. Remember, so we're talking about lung cancer screening here. So if you have a tool that can do one thing, you might as well try to ask it to do 2 things, and that's what I did here. So just a little bit of background, structured reporting, I'm sure everyone in the audience uses it. Actually, maybe just show of hands, just so I could see. How many people are using structured templates in PowerScribe? Yeah, most everyone, but not everyone is, right? And I understand why, but I'll tell you, there are tons of papers out there that talk about the benefits of structured reporting, and so I quote here, structured reporting is thought to, and I don't think it's thought to, it does improve the consistency and reproducibility of the radiological report. This improves readability, clarity of the report, but also facilitates, this last part's very important to me as a quality person, facilitates data mining in clinical or research setting. It's a very easy way to gather that data. So if you have disease-specific structured templates, you know that data that you may want is always going to be in the same place in the report every single time. So that's a very easy ask if you go to your IT department or your informatics department and say, hey, I just need every report with this CPT code in this area. I need that data put into Excel file. That's so easy for them to do. Like probably you're a high school student with a little bit of background in programming could do that for you. So this is not a heavy lift for someone who's working in that department. Okay, so here's another QR code here. This QR code, is actually will take you to the ChatGPT chatbot. I create a chatbot, which will, number one, create structured reporting, and then also will give you the lung-RADS category based on the description of the nodule or mass that you put in that free text, okay? I love and hate structured reporting. Structured reporting, again, extremely powerful. I told you why. It's awesome from a standpoint of data abstraction, right? From reproducibility, from decreasing heterogeneity reporting. It's awesome. But I hate it in my workflow. When I pull up a report, when I pull up an imaging study and something pops up on my Fluency or my PowerScribe, I don't want to look at this non-diagnostic screen, right? You don't make awesome diagnoses looking at your screen where you're reporting. You make awesome diagnoses when you're looking at the diagnostic monitor. So anything that takes your eyes off of the diagnostic monitor is not advantageous. It's not the way we should be working. And so for me, with this structured template, I have to go from the tab to tab to tab to tab. I've got to remember where I am, and that increases my mental load, just makes it harder for me. And so for that reason, I like to just free text report. Right? So that's what I'll do. I will free text report. I'll just keep my eyes looking at the diagnostic monitor. I'll get the free text and put it just in some area within a PowerScribe or Fluency. And afterwards, with a little bit of a keyboard shortcut and auto hotkeys, I can copy that, put that into ChatGPT, and run this algorithm. It's actually pretty awesome, right? Again, very, very powerful to be able to use an LLM that can do this. But you guys are probably wondering, well, how good is this actually? So for completing sake, this is the chatbot I created. This is the interface. And so if you want to do this yourself, you can. You can create your own chatbot. We'll do the exact same thing. So I created this chatbot. I put in the PDF, which is the Lung-RADS 2022. I'm also on the Lung-RADS committee, as Dr. Prosper was saying. I can only remember about 60% of it, right? There are all these nuances in there. I can't put it in my head, right? I'm a firm believer of memory is sort of like penguins on an iceberg. There are only so many penguins on that iceberg that can be there in your conscious memory. So the more you try to memorize, some of those other penguins get pushed off. So if you don't need to memorize it, you shouldn't memorize it unless you're using it multiple times per day. And so anyways, this is helpful from that perspective as well, because this can guide you toward the specific lung category that it thinks is appropriate. And so this is a structure here. I think you can see it. So this is a structure that I taught it to learn, pretty basic. Actually, this is a little more detailed than the usual template at UCSD. At UCSD, it's a very, very compact template for lung cancer screening CT, because we just want to get to the point. Is there cancer? Is there not cancer? Or is there anything that's suspicious for cancer? And everything else we put into just a different, like a heterogeneous section by itself, like any other potentially significant findings. And that makes it faster, but that would have been too easy for this chatbot, so I made it a little bit harder. And so then here's the prompt that I gave. I was like, well, you got to test it, right? And so here it is, 7mm solid pulmonary nodule and all this other stuff, which is completely not structured at all. This is just free text. And we run the algorithm, and what we get does really well. Here's the findings, right? So it puts everything in the right findings. Also, you know what I found? I don't know what's wrong with me. I think I have blindness to my own dictations. Because when I create reports, all the little typos or grammatical errors, which I would never let slide if a trainee sent me a report, when I generate it myself, they get through all the time. It's like my brain doesn't see it because I generated that, I recognize that text, and so somehow my brain just kind of glides over it. ChatGPT will pick up all those things, and it'll fix it for me. And then sidedness issues as well. It always picks up sidedness issues. Every once in a while I have some sort of brain issue where I'll say right upper lobe nodule in the findings, or then later down in the findings I'll say left upper lobe nodule, or in the impression I'll say left upper even though it's a right upper in the findings. And this will also pick up on that. It's actually really amazing. So findings does perfectly. Impression, it did great as well, so it gave the appropriate lung-RADS score here. The problem is we also have this lung-RADS category. For some reason, it decided to put the cyst in there and cholelithiasis. Maybe the cholelithiasis put in there. And so again, LLMs, you have to keep tweaking them. You have to keep training them. And so I just trained. I told them, no, those are not clinically significant S findings. And I showed them a ton of examples of what S findings were. And so then on the next iteration, it did not put that into the S findings. So very powerful ability to do these kind of things. I encourage you to play with it. I think will make you, a better radiologist. It certainly makes me faster. It's maybe increase my efficiency by 10%, and it's made my reports far better because, again, a lot of those little grammatical errors and spelling errors that I let slide through, they get caught by ChatGPT. It's like a secondary check. All right. So now we'll finish up with this last thing. This is email generation use case, which sounds a little bit odd, but I'll show you why I'm actually bringing this up. So here, more than anything, I just want to bring out the amazing functionality of large language models for creating programming code. Again, I have no experience with programming code, not even in high school. So if I can do this, anyone in this audience can do it. It really is. This is actually quite simple. And so here's the use case specifically. If there is a nodule that I think is concerning for either lung RADS 3 or 4, so it's actionable, and I want to email the ordering provider as an extra layer of patient safety. I think that this is very much appreciated by the clinicians as well, so it's a nice way to sort of develop relationships. The clinicians, at least at UCSD and probably University of Chicago as well, the clinicians don't come down to the reading room anymore. So if there is some way where you can communicate with people a little bit more and like kind of keep that relationship active in some way, even if it's in this asynchronous, non-face-to-face manner, I think it is helpful. Obviously, we want to do that. We want to cultivate relationships with our ordering providers, okay? Excuse me. So as you can see from this prompt, I'm asking ChatGPT, so essentially a bot, to write me Python code such that I can populate an email with as few clicks as possible. And so my assumption is that because I'm going to do this, because I have this in place, the reason why I want to put this in place is because I want to do this. I want to do this multiple times per day so that I can, again, interact with my clinicians, but also increase safety for my patients. So there's a little bit of a tangent, but I think it's important here. So based on this prompt, you can probably glean why I crafted that prompt in that way. This is a pretty go-to method for creating prompts for LLMs. And so it's the Cisco method, right? So you want to tell that LLM what the context is. So who the heck are you? What character are you essentially playing? The intent, what are you actually trying to achieve? The style, so what style should they be presenting the text in on the output? And then the command, exactly what the heck you want them to do, right? This is actually very important. So the more complex the use case, the more your prompt is going to be comprised of these commands. And obviously then the outcomes. So where do you want the outcomes to be, like in terms of formatting? And so here is a code for anyone who wants it. Try it. QR code bottom right. Have fun. Note that the string of code here is actually not that crazy. Python's relatively efficient. I think I probably could have Googled this. I probably could have probably used Reddit and Google to figure out how to write this myself. But that probably would have taken me couple days, at least a couple days, to figure out full days, and then problem solving this and that. This took about 10 minutes. The first iteration, I'll tell you, if you do write code in LLMs, the first time it doesn't work, right? So then you have to, when you run it, you put it back into ChatGPT, the interface that you used to create it, put it back in there, and you tell it that it didn't work, and then it will debug itself. And then you do this a couple times, and then it works. Why does it do that? Why can't I do it from the first get-go? I don't know, but it works, but it will even debug itself. So here it is. I copied this impression into the clipboard. I ran it, and boom, it creates an email, automated email. So you're like, yeah, this is not rocket science, right? I could have done this. I could have typed all this out, right? But I did this in 2 clicks instead of 15 clicks, and didn't have to type anything. And if you do it 10 times a day, this is good for your mental load, good for your wellness. And again, this is good from a quality perspective. All quality work is removing hurdles and things that you want people to do, and creating friction creating friction for things that you don't want people to do, right? So we want people to communicate with clinicians, remove all the hurdles, make it so simple that it's almost like precognitive. And this is one way to do it. Okay, I'm going to skip this for now for sake of time. I will say that for yourself, I guess I'm not skipping. I just got to say it. So there's an activation energy if you want to do this, right? You have to you got to sit down for an hour and you have to make something like this, right? And so the best way to actually get excited to do this, because people are predictably irrational, so you care about yourself more than you care about your future self. That's why people smoke. That's why people eat bad food now, because it feels good now. But that's future Jonathan's problem. This cake that I'm eating, That's why I agreed to do a book chapter that's due a year and a half from now, because that's future Jonathan's problem. Of course I'll do that book chapter for you. I'd love to do that book chapter for you, because it's not my problem right now. 1.5 year Jonathan will have to deal with that, right? So it's funny how we devalue things in the future as opposed to valuing things right now. But anyhow, the best way to do this, I think, is to talk to someone who's already done it. So I've done it, right? And get excited about it. That's the best way to do it. So anyways, conclusions, I think LLMs are here to stay. I encourage you to use them. There's a lot of use cases, especially in the setting of lung cancer screening. And picture of my kids. Thank you so much.
Good morning. My name is Terrence Healy. I'm from Brown University. I'm the director of CHEST, and this is going to be a little bit different. I'm going to talk about how to build a decentralized lung cancer screening program in a community setting. There are lots of people that work at big academic centers, and they have really sophisticated ways to do lung cancer screening. But in my opinion, if we're going to tackle lung cancer screening, we need champions. I consider myself the Rhode Island champion of lung cancer screening. So this goes far and above how you read the lung rads. It's how do you build the program? We don't do all of our mammograms in our academic medical centers, right? Imagine if we only had lung cancer mammography at big centers. We would not do very good at mammography. Likewise, we need to teach people how to do lung cancer screening from their outpatient offices. There's lots of good ways. This is a 128-page guide, how to do it. It's mostly a centralized system. There's a very nice article, and notice that a lot of this information came out in 2015. This is the MGH group, the 10 pillars of lung cancer screening. And 2015 was an important date because that's when CMS approved coverage of lung cancer screening. Now, we all know about the National Lung Cancer Screening Trial. This was the letter the patients received on November 4th of 2010. This was on every news, major story, evening news, lung cancer screening is here. Okay? I really enjoyed seeing the letter because this directly applied to my patients. At our major hospital, we had 826 patients enrolled in National Lung Cancer Screening Trial. So immediately, what did I do? I purchased and developed a website called rilungcancerscreening.com to start to put stuff on there, to update it throughout the whole process of lung cancer screening. Also teamed up with, as smoking cessation was such an essential part of doing this, we as radiologists have to actually figure out how to do this. So I teamed up with our local QuitWorks Rhode Island, and we incorporated smoking cessation as part of our screening. Okay? Was basically told I had to establish a cohesive product throughout our network, and we have a very complex network. Our radiologists, there's about 100 of us, we cover 3 different healthcare systems who all don't like each other. They're all competing for patients in a small state. We have 1 major academic medical center. That's where our patients were enrolled into the NLST. We cover a total of 11 hospitals, and we, the radiologists, own 16 outpatient imaging centers separate from the hospital center. So as you can see, I don't really have a centralized system. We need a decentralized system. You need a champion. Own lung cancer screening. Radiologists should own it. Develop protocols with appropriate billing codes. You need follow-up protocols for all these lung rads, the 3-month follow-up, 6-month follow-up, different billing codes for each of those. Figure out how you're going to accept the order. Are you going to accept only electronic orders, paper orders, verbal orders? How long are you going to take to scan these patients? Again, no contrast necessary. These are quick. They take less than 5 minutes of room time. We need to come up with a questionnaire to collect accurate smoking data and other data so that we can do research and quality. We need to be able to transfer our data to the ACR registry, and initially this was a requirement. So how can you do that efficiently? How can you use IT to track these patients, report our lung rads rates, do QA? How about generating a letter? Is there anybody out there that sends their lung cancer screening patients a letter? Yeah, I might be the only one. That's coming, but mammography patients get a letter. All of the patients that get scanned at our outpatient imaging centers get a letter from me because I'm taking over the lung cancer screening. So I'm taking responsibility to let the patient know when I recommend a follow-up. So I'm not leaving that all to burden the primary care doctors. This is our PowerScribe template. And again, these are acquired forms. And we have put smart guides in there. If you give someone a lung rads category 2, we're not going to allow you to bring them back in 3 months, okay? It's going to only offer you a 12-month follow-up. And these are things that we should all integrate, just like Dr. Chung alluded to. And also, we make required fields like dose over here. These are requirements for ACR reporting. So it's all automated, required, and some of these are actually imported in through the CT. So some of these are automatically populated in our PowerScribe reports. This is the letter. Even if I didn't read the study, everybody that goes through our outpatient center gets a letter. And the letters are based on the lung grad score. So this would be lung rads 1 or 2. They come back in a year. Someone in your practice has to establish grassroots efforts because smoking is a huge stigma that permeates society. We need to educate clinicians, doctors, nurse practitioners, PAs, anybody who can order these studies must educate them about the benefits of lung cancer screening. How can you can save your patients' lives by ordering the study. We also have to get the word out to the patients in the community that this is available. One of the most important things that I can tell you is find out what the barriers are. Get out in there and talk to people. I only found out because after I gave a talk in the community, somebody came up to me and said, the patients in my practice can't get to any of your outpatient sites. There's no close bus stop to any of your sites. So what do? We had to come up with a problem. We now provide Uber ride service for anybody who's going to get lung cancer screening to and from our closest site. So that was a solution. There are cultural barriers that some of us don't talk about. We got a little grant from the American Cancer Society, and we did some focus groups. The biggest one was with Progressive Latino. And there were specific barriers to each of these communities that we addressed formally with people from their communities. I go to lots and lots of meetings. You got to team up with your local pulmonologist, oncology, and surgery, because these patients are getting scanned outpatient, so they don't have a direct link to the medical center in most cases. So as a radiologist, we have to establish the link to be able to get these patients in and seen by specialists in an efficient manner. We have to teach our referring clinicians about what is this lung cancer screening thing, and make it easy for them. This is a meeting that I had in February of 2019. I met with State Department, Rhode Island Department of Health director, the director of the Cancer Registry, some public affairs people from our Brown School of Public Health. I met with some mayors, community activists, and then I've had many meetings with industry, and I'll get to that in a few minutes. But here's just the picture. We just team up, have a little meeting, talk about how we do lung cancer screening, why we do it, and again, the importance of it from a public health standpoint. Get involved in the medical school curriculum. Talk to house staff. These are our future referrers. Teach them about lung cancer screening. Talk to medicine, peds, triple boarder, surgery, family medicine, and there are 2 local PA programs in our state that I give lectures to every year. Now, marketing. I know nothing about marketing. I kind of figured out how to do this. We have brochures that we put in all of our 16 location waiting rooms and online. Smoking cessation is available in every office's waiting room. And we actually do radio advertising.
Cigarette smoking is the leading cause of lung cancer. Approximately 200,000 people in the U.S. are diagnosed with lung cancer, and 159,000 die each year. Studies have shown that early detection with lung cancer screenings using low-dose CT scans reduces lung cancer death by 20%. As the only diagnostic imaging center of excellence in southeastern New England, Rhode Island Medical Imaging combines the latest in CT technology with radiologists who specialize in lung cancer screening. If you are currently a smoker or previously a smoker between the ages of 55 and 80, you could be eligible for an annual lung cancer screening that could detect lung cancer in its earliest stages when it is the most treatable. Ask your doctor to refer you to Rhode Island Medical Imaging for your annual lung cancer screening. Or for more information, go to rilungcancerscreening.com. Rhode Island Medical Imaging, world-class medical imaging, focusing on you.
So we ran this for a long time, about 6 months, and it resulted in a huge increase in number of referrals. We also teamed up with a more grassroots effort. This is the Lung Force Walk. You can see that we started doing this in 2017, and we've been doing it every year since. These are all employees of our outpatient imaging, of our team. There's about 100 people from Rhode Island Medical Imaging. These are technologists, administrators. You give them a free T-shirt, have them raise some money, and go to the walk. Spread the word about lung. And at this walk, actually, they introduced me, and I tell all of the people involved in the walk about lung cancer screening, what it's done for me, my family, and my patients. What about corporate wellness programs? Well, we did these 25-minute lunch and learn programs. I would go to big employers like Fidelity, Amica, and CVS, and just give a little update, like I'm talking to you about lung cancer screening, why it's important, how it saves lives, and this is another way to gain business. Now, you also want to, train our doctors. How do you do it? Like, how do you get access to your high-volume referrers? Well, what we did is we rented a box at one of the, the minor league Red Sox teams. We invited providers to come, and I gave a little talk for a half an hour before the game. You can see the kids there. They have a good time. We sponsor little league teams, so there's one of our Rhode Island Medical Imaging shirts, the guys on the field. and we were able to access all these refers at a baseball game. We had additional teams from other cities come to this barbecue event, and it was a really nice event. And again, a way to spread the word, grassroots efforts. We all do CMEs. At our Brown CME courses, we include lung cancer screening in almost all of them. And we've been doing this since 2015. Again, notice the year 2015. This is when lung cancer screening started regular coverage. Last couple minutes, I want to just talk about social media. I mean, we are very active on social media. Everything that we do about lung cancer screening goes on our social media. Here's an interview with one of our local news agencies. This is actually an expo that we sponsored and I gave a talk at with the Lung Force again. Put it on social media. LinkedIn, we put everything that we do on LinkedIn. This is a radio. I got interviewed by one of the local radio hosts. And again, Facebook. This is Dr. Agarwal actually wrote this article here in the Providence Journal about lung cancer screening. So social media is a big way to get patients into your lung cancer screening program. And I think it works. I want to have you just look at this for a minute. 2015, far right, 347. The yellow is lung cancer screening, and the blue is a reference of high-res chest CTs. So there's really no reason for high-res chest CTs to go up, right? There's no new indication. It's kind of stagnant. It goes up because all of imaging goes up. Look at the rate of lung cancer screening from 2015 up to the third quarter of 2024. This is just at our outpatient sites. This is not any of our hospital systems, which is completely separate from this. So big strides in lung cancer screening volumes. Now in terms of quality, Dr. Chung alluded to quality. And if you look at, I'm not going to go through this. This is a complex analysis we did with one of the ACR groups to look at all the steps that go into actually doing lung cancer screening appropriately. This qualification period, you got to get the order. You need to get the pre-authorization. You got to obtain the CT. You got to get the prior reports, which could be at any of these institutions outside of our outpatient imaging center. And it turns out that this is our QI coach. The process of qualifying a screening is so complicated and requires so much time that patient appointments are regularly being canceled. On top of that, no one has the time or capacity to follow up with these canceled cases. So we did a very complex analysis, and we discovered that 30% of our canceled appointments are due to issues with authorization. And this is just our practice. These are all the indications, age, PAC years. Look how much the insurers are varied in terms of their coverage. If you look way over to the right here, where it says check RIMI, that means that our outpatient imaging centers can actually get the authorization. So all of these plans that don't have the RIMI over here, the office staff is burdened with getting authorization. And that's really what resulted in this problem. This is our lung cancer screening coordinator. A great deal of time is spent guiding providers and their staff on when and how to order lung cancer screening versus lung cancer screening follow-ups versus CT chests without versus high-res chest CTs. The insurance guidelines for specific authorizations require guidance and other orders. So this is a very complex, it seems like it should be so easy, but it's not. So what did we do? We did make some interventions, and the whole point was to make the process of doing lung cancer screening as easy as possible for referring providers. We created a Teams channel so that any of our referrers can directly get into correspondence with our coordinator without a phone call. Instead of faxing paper orders, everything can be file shared securely. This is the type of team you may need to run a decentralized program. You need a chief operating officer, you need a radiology champion, you need a QI coach, you need some CT techs, you need a coordinator. And of course, I talked a lot about marketing. We have a marketing director in our group who helps me tremendously build the lung cancer screening program on the outpatient basis. I do want to thank the ACR Learning Network for some of our research into our processes. And this is hot off the press. In Rhode Island, 28% of those high at risk were screened, which is significantly higher than the national rate of 16%. We rank first among all states, placing it in the top tier. So you can do it. You can build it outpatient. You don't need to be an academic medical center, but it takes a lot of work, and I think we have a lot of way to go till we get lung cancer screening to where it needs to be. So thank you for your time, and I think we have like maybe two minutes for questions. Okay, if there's no questions, the speakers will be up here for about 5 minutes if you want to come up. Oh, I have a question.
Hello, hi. So I have a query regarding cystic lung malignancies. Sorry, I just missed the initial part, but regarding staging, when you see a cystic tumor in the lung, so most of the time the solid component is quite small, and the cyst will be quite large, around 3 centimeters, quite thin wall. And when you do a PET scan, of course solid component will take uptake, but not a cystic wall. So when you do a local staging of T, do you include the entire cyst or just a solid component?
So your question, just to repeat, is how you would stage. Would you change the way you stage something based on its appearance?
Yes, based on the size, whether you include both the cyst and the solid or just a solid component alone.
So interesting. I don't know that that has been included in the official staging guidelines. Do you do something different at your practice, or?
When we discuss this, we generally include the entire component, if it's PET with. But sometimes the pathologist shows less, the T staging be downgraded. Just had a query whether you, in your practice, you include the entire cyst or just a solid component alone.
You know, a lot of the way that these are managed is still by that solid component, because most of the times, if they're going to be aggressive or metastasize or do anything else, that's oftentimes on the solid part. But as far as if it would change our management, for example, in one of the cases I showed, we still got a PET just to see, is it avid? And that still led to the patient getting that resected. That said, I do think there needs to be, because we're recognizing these more work and incorporating those into official staging guidelines would be good.
Yeah. The other quick thing is regarding sometimes the solid component will not be uniform. It will be like along the superior wall solid and maybe inferior wall solid. So again, you can't combine them both as a single tumor. So is that, how do you stage that, or how do you go about it?
So you raised another really good point before I answer that is, when you're looking at these, it's important also to look on sagittals and coronals, because sometimes if you're looking just on the axial plane, you might not recognize the fact that there is some thickening at the, the upper part or the lower part. In general, when we've been doing wall thickness, kind of measuring one area, not kind of adding them together or anything like that. And then you'd kind of base your management based on the thickest part.
Good, thank you.
Okay, one more question.
Yeah. Just to ask about when do you perform the biopsy, which stage, 4B for cystic lesion, and do you do PET-CT prior to the biopsy?
So that is a very good question, because if you just had a cystic lesion and you have a very thin kind of solid compartment, you biopsy, you're not going to get anything because you're going right into the cyst. And so I think this is different based on, the whole kind of scenario. So if you have a thicker part, you might go ahead and biopsy, but in places where maybe it'd be hard to biopsy, either based on location or the fact that, it's kind of, mostly kind of ground glass or mostly cystic, in those cases we might get a PET first.
For 8 millimeter, we do usually when you have thickness of 8 millimeter.
Yeah.
But the question is, do you do PET prior to the biopsy or no? When
So
you have 8 millimeter.
a lot of times we do, mainly because I can help guide your biopsy.
Okay.
If there's a part that's very avid, then maybe you want to target that.
Okay, thank you.
What about you?
I do these, but I always do PET because it guides my where to place the needle.
Yeah.
Thank you.
Yeah, in addition, the PET will help, especially if you have a metastatic nodule in which you can get to bronchoscopically and both stage and diagnose the patient. So that's another reason why you want to do the PET before the biopsy. Great. Well, thank you so much for your attendance. Enjoy the rest of the day, and thanks for coming.